communication portion of this meeting must have registered with Central Health via the online forum or by telephone no later than 11:30 a.m. today. Anais, anyone registered to make any comments today?
No, not today.
Great. We will now proceed to the committee agenda. I'd like to start by welcoming our newest members, Board of Managers Brinson and Motwani, to the Strategic Planning Committee. Welcome. Glad to have you here. Look forward to working with you on the committee's important mission and getting your input on many of these great topics we're going to talk about in today's meeting and in future meetings. Thank you both for joining us. Also like to comment and just remind the members that we have been trying to make sure that we have a fairly short meeting, and then the meeting that follows that meeting will be a fairly longer one. This is our fairly longer one today, although there are 3 items. They're pretty hefty in discussion. So we'll probably take up the full hour and a half for this one, and hopefully I can make the next meeting a little bit more brief for us. So just a heads up on that. Agenda item number 1, review and approve the minutes of the February 10th, 2021 meeting of the Strategic Planning Committee. Can I have a motion? Anybody?
I'm happy to move to approve the minutes of
Right.
the February 10th meeting.
Okay.
And I second that.
I have a motion from Manager Motwani. I have a second from Chair Greenberg. Any discussion? All in favor?
Aye.
And any abstaining? Motion carries. Agenda item number 2, receive an update on the FY 2021 systems planning priority related to disparities in chronic conditions and demographic enrollment trends within Central Health's patient population. We have Sarita Clark-Leach and JP Eichmiller will be presenting this to us. So I think
Dr. Bell, I believe Mr. Motwani had a question.
Oh, I'm sorry.
Just as a procedural matter, I just wanted to let you know that despite the fact that I moved to approve those minutes, I did abstain. I did abstain on the approval, unless that affects the approval.
No,
it's fine. It's fine.
it's
Thanks.
fine. Would you please show Manager Motwani abstaining in the minutes, please? Thank you very much.
I appreciate it.
Sorry I missed you there. And so I think JP's going to kick agenda item number 2 off. And so I'll turn it over to him.
Thank you, Dr. Bell. Can you see the full screen?
Yes, I can.
Okay, great. Yes, my name is JP Eichmiller. I am the Senior Director of Strategy and Information Design, and I'll be presenting today on the demographic enrollment trends. And then Sarita will take over, and she'll be providing some new data on disparities in health among Central's patient population. Just before we begin, I just want to emphasize this work is a priority component of the systems planning work that has been adopted by our board. This is all about access to coverage, access to care, and understanding how those need to fit within our larger system. I'd also like to emphasize as we go through this presentation that we look at this data as an opportunity to learn from what we've done well and not just to focus on where we could do better. For example, much of the information I'm going to show you tells us that many of our efforts to reach vulnerable, non-citizen, non-English speaking populations in our rural and suburban areas of the county have been successful in many ways, and that we now have the ability to achieve similar success within other subpopulations. Okay, so again, this is a system planning priority, which is understanding and analyzing the changes in enrollment that relate to people, place, and time. This is a first for Central Health. What I'm about to show you, we were able to collect year-over-year changes in the MAP, MAP Basic, and sliding fee scale addresses. We've never been able to do this before and analyze this at a census tract level, so it's really exciting. And what this does, more than just provide us with simple maps, is it gives us the ability to look at over time snapshots of our populations, looking at racial ethnic groups, looking at our homeless populations, non-citizen, and justice involved. This is also the very first peak, the very beginning of our look into some of these new data sets, and we anticipate being able to present much more in the future. As a final point before we get into it, I'd like to emphasize that this enrollment analysis will show some similar demographic patterns as what you'll see in the health disparities later from Sarita. However, we're not ready to provide any direct correlation or causation at this time. So this is the map of our enrolled 2019 population. Many of you may have seen this already. We presented it with the demographic report. And this is the first time we ever were able to look at our populations at the census tract level. And here is the FY 2020 map. And at first glance, it probably looks pretty similar to you guys, but we will go through, there were actually some pretty significant changes between FY19 and FY 2020. One thing I can tell you to begin with, if you look at the key, the highest range of enrollees of any census tract we had was about 3,000 in 2020. That was down from about 3,600 in 2019. And here's a quick view at how those changes occurred year over year. As you can see, we saw some really sharp decreases in these areas, some of these areas that are in the brown. Essentially here, what you see, these census tracts in the browner color, we all saw decreases greater than 50 enrollees. The tan, somewhere between 50 and 25, a decrease year over year. And then these grayish areas, little to no increase or decrease. And then in these green areas, this is Manor, this is far east Pflugerville, and then we've got some unincorporated areas of Travis County here. Lago Vista, we actually saw some increases last year. But for the vast majority of the areas where Central Health enrolls people into its programs, we saw very sharp decreases. In fact, in areas such as Colony Park, we saw decreases in excess of 400 enrollees, somewhere between 400 and 800 enrollees year over year, as well as in parts of Dove Springs and the Travis County Correctional Complex. We also saw some pretty moderately high decreases in areas of Runberg, East Austin, Montopolis, and Manor. Now we're going to start to look into some of the demographic, racial, ethnic enrollment trends for 2020. First, we're looking at our Black enrollees. And what we're going to be looking at these next few slides is what percentage of our enrolled population belong to a specific racial ethnic group. So when we look at the Black enrolled population, what we see where we have the highest rate of representation remains in East Austin in these census tracts to the west of 183, to the east of I-35. We've also got fairly high rates in areas such as Wells Branch and Pflugerville to the very north. However, conversely, we see very low rates of Black enrollment in the southeast and Del Valley. And we also see fairly low, below 12% in areas, historically Black neighborhoods such as Colony Park. This is the Latino enrollment, and the proportion of Latinos really dominates the areas where Central Health draws most of its enrollees from, with the exception being East Austin and the Lago Vista, Jonestown areas to the far northwest. But otherwise, when we look at Runberg, unincorporated Travis County to the north, Manor, County Park, Hornsby Bend, Del Valley, Dove Springs. The Latino population represents usually about 3/4 or more of our total enrolled population. This is also true in areas where we have not insignificant enrollment in the West, such as Oak Hill and Apache Shores. And then finally, we're just, this is a peek at our white enrollment. As you can see, white enrollment as a percentage of total enrollment is fairly low throughout the eastern portion of Travis County, the exception of Pflugerville to the north. The one exception within, the biggest exception is the Travis County Correctional Complex, which is right here next to the airport. That is actually where we draw that census tract is where we draw the most white enrollees of anywhere in the county. So I'm going to go through our summary findings here real quick with you guys. So overall, and this is the first time I'm aware that this has ever happened, certainly since I've been at Central Health for 6 years, our overall enrollment decreased between 2019 and 2020. It decreased by about 13,400 enrolled members. And this was primarily driven by losses among the MAP basic and sliding fee enrollees. We lost about 10,400 year over year. Latinos are by far have the largest representation among our enrolled population. Latino enrollment is about 10 times larger than our Black enrollment and about 6 times larger than our white enrollment. And if you look at some of those different programs, in some areas it's even more pronounced. Our Latino enrollment in MAP Basic is 17 times that of our Black enrollment. Year over year, we see a much higher rate of dropout among our Black and white enrollees and Latinos. Between 2019 and 2020, about 43% of our Black enrollees did not return in 2020, which is about 15% higher rate than Latinos. About 38% of whites did not return in 2020, which is about 11% higher than Latino. So our Black enrollee population is unique in that it's the only one where we enroll more in MAP. We enrolled about 2,000 more Black members in MAP than in MAP Basic. Whereas you look at the Latino population, we enrolled 21,000, almost 22,000 more Latinos in MAP Basic than we did MAP. So it's possible we may be missing some opportunities to capture Black enrollees in that 100 to 200% FPL bracket. Homelessness compromises a much larger portion of our population among the Black and white enrollees. It's about 1/4 for those two compared to 3% of our Latino enrollees. We can also tell you that our homeless enrollees are overwhelmingly US citizens, English speaking, and male. And then finally, as I alluded to earlier, that census tract with the Travis County Correctional Facility has the largest concentration of Black and white enrollees of anywhere in Travis County. And that is it. Before I pass on to Sarita, I just wanted to acknowledge all the great work that Ashley Levulet did for this. She'll be presenting a little later, but I really can't emphasize enough that we've come a long way in the last 2 years to be able to present this type of information to you. And I thank Ashley and everyone else on Sarita's team who helped contribute to this.
Thanks, JP. So we're now moving on to our health equity portion of this presentation. And we're going to kick this portion off with the Robert Wood Johnson Foundation definition of health equity. And that is when everyone has the opportunity to attain full health potential and no one is disadvantaged from achieving this potential because of social position or any other socially defined circumstance. And now let's define health disparities, since we'll be addressing them in this presentation. Health disparities are health differences that are linked to social, economic, and/or environmental disadvantage. They negatively affect people who have experienced controllable, systematic barriers that leave them vulnerable to poorer outcomes. In considering some of those controllable risks that contribute to health disparities, they are structural and systemic racism, implicit bias in the healthcare setting, poverty, which contributes to lack of access to healthy nutrition, lack of access to safe spaces, exposure to poor environmental conditions, such as poorly maintained housing, and exposure to polluted water, air, or soil, language barriers, barriers to health literacy, and transportation barriers. So we're going to be focusing on our fiscal year 20 MAP and MAP basic population, which comprised 92,651 individuals. And the metrics we'll be examining are disease prevalence and clinical performance measures, which are disaggregated by race, ethnicity, sex, and homeless status. And looking at this at a high level summary of findings, we found that compared to the whole central health population, rates of disease are generally higher among Black and Asian race groups, non-Latino, male, and homeless populations. And looking at the clinical measure performance, it's generally lower, below average, I should say, for non-Latino, non-white, non-Latino, male, and homeless populations. We're often, understandably, we're often asked to compare our disease prevalence rates for our central health population to those reported by Travis County. We're hesitant to do so because the comparisons aren't apples to apples, because there are differences in how the data are gathered. The BRFSS, or Behavioral Risk Factor Surveillance System, is a self-reported survey where people are asked, have you ever been diagnosed with X? So again, this is not necessarily something that's based on a documented diagnosis within the patient's historical medical record, but that is what we look at. We're looking at documented diagnoses that indicate these chronic conditions. And we also have to bear in mind that while BRFS reports on folks 18 plus at all income levels, that our population is generally younger and more diverse and more economically disadvantaged than the rest of the Travis County population. So it's hard to make definitive statements like the incidence of hypertension is lower for central health population for the general Travis County population. We created this heat map to provide an easy visual for disease prevalence, allowing you to see which populations are disproportionately impacted by chronic disease burden. Gold values indicate that there's a lower disease burden relative to the overall population. The darker the gold, the lower the burden. Blue values indicate a higher disease burden relative to the overall population. The darker the blue, the greater the burden. As you can see, Central Health's Black, non-Latino, and homeless populations experience the most disease burden relative to the overall population for those chronic illnesses. Moving on to clinical performance measures. Again, the same schema here. We're looking at gold is better than the overall population, blue is worse than the overall population. The darker the color, the greater the degree. The differences here aren't as great, but again, Black, non-Hispanic, and homeless populations have poorer results relative to these clinical measures. While there's certainly work to be done to address the noted prevalence disparities for most of the chronic diseases identified in previous tables, we would recommend a continued focus on hypertension and diabetes, as they are the most prevalent disease conditions in the central health population. They have common underlying causes and shared risk factors. They contribute to worsening of each other's symptoms, and can eventually progress to organ failure. And ways of managing both conditions overlap. And they include nutrition management, regular physical activity and movement, and medication management. So looking specifically at disease prevalence for hypertension and diabetes, again, you'll note that gold is better, blue is worse. There's a higher hypertension burden among Black, Asian, non-Latino, male, and homeless members, and a higher burden of diabetes among Black, Asian, Latino, and male members. And a similar pattern can be noted for clinical performance measures results, where we see Black, non-Latino, and homeless folks with lower rates than the general population. Moving on to hypertension. Hypertension, the silent killer, is a major risk factor for heart disease, stroke, diabetes, and kidney disease. It's also the most prevalent in our condition in our population at 24.4%. In looking at these clinical performance measures, we'll note that blood pressure was adequately controlled among 65.9% of adult MAP and MAP basic patients with a history of hypertension. Here's a look comparing prevalence rates of the different groups within each demographic category. The thin vertical line across the horizontal bars represents the prevalence rates for the overall population. And looking more closely at this, in the race category, you'll see that rates of hypertension are highest among homeless individuals, regardless of race. But Black members have the highest burden of hypertension and the lowest rate of blood pressure control. Asian members had the second highest rate of hypertension, but showed the best rate of blood pressure control of all race groups. Comparing ethnicity, Latino and white populations have the lowest rates of hypertension and also have above average rates of blood pressure control. Males overall have higher rates of hypertension and have below average rates of blood pressure control. And relative to homeless status, a high number of homeless members have hypertension at 37%. And keep in mind, again, the overall population is 24.4%. And of those in care, 54.2% have adequate blood pressure control. And Black patients experiencing homelessness have the highest hypertension prevalence at 47.1%. So what can we do to mitigate some of this impact and these poor outcomes? So again, looking at alignment with systems planning around hypertension, these are different interventions that can be provided. And we can identify and implement measures to apply value-based performance payment with the specific goal of closing the disparity gap between populations. And we can also ensure parity in the distribution of these interventions. We can encourage and collaborate with primary care providers and pharmacy on targeted interventions and to mitigate some of this impact. Moving on to diabetes. Diabetes increases the risk of cardiovascular disease and infections, including COVID-19, and is a leading cause of kidney disease, vision loss, and lower limb amputation. Overall prevalence for diabetes in the central health population is 14.3%. And looking at clinical performance measures related to diabetes, we see that blood sugar control is at 48.4%, which is below 2018 benchmarks. Blood pressure control is at 75.2%, which is above 2018 benchmarks. Nephropathy screening and annual foot exams are both at benchmark. Again, a quick look comparing prevalence rates of different groups within each demographic category. The thin vertical line across the horizontal bar represents the prevalence rates for the overall population. And now we're going to take a focused look at the differences between race. Among the Asian Asian and Black populations have the highest rates of diabetes. Rates of diabetic blood sugar and blood pressure control for Black patients are near the bottom among all race and ethnicity groups. Blood sugar control is highest among Asian patients, but blood pressure control is below the population average. Looking at ethnicity, 15.4% of the Latino population have diabetes compared to 13.2% for non-Latinos. Latino patients perform above average on blood pressure control, but underperform on blood sugar control. And then looking at sex and homeless status, males perform below average for blood sugar and blood pressure control. And homeless members have lower rates of diabetes than the central health population, but perform the worst of all on the clinical measures. Again, in terms of aligning with our systems planning around diabetes, we would identify and implement measures to apply value-based performance payments with the specific goal of closing disparity gaps between populations, and again, ensure parity of distribution of those services or interventions among the different subpopulations, encouraging collaborate with primary care providers, and perhaps note further note subpopulation differences. For example, a focus on Black females who buck an overall trend in that they are more likely to have poorer outcomes relative to their counterparts. So now we've measured, disaggregated, noted disparities in health, and now what? Let's revisit some of the contributors to health disparities, which include structural and systemic racism, implicit bias in healthcare setting, poverty, language barriers, transportation barriers, and barriers to health literacy. And what can we do to mitigate some of those barriers? We can learn from the success with our Hispanic Latino populations and apply them to other subpopulations. Achieving health equity requires community effort. Central Health can't do this alone. Its partnering organization, local governments, and community activists will have to work together and separately to create just social, economic, legal, and environmental conditions that allow for health to flourish. Central Health is taking an equity-focused, systems-based planning approach toward mitigating disparities. We'll continue to monitor clinical outcomes disaggregated by demographic as well as clinical attributes. We'll consider the whole patient individually, meet them where they are, and empower them when you can. Engagement is key. Healthcare workers, and when I say healthcare workers, that's everyone who is employed by Central Health and our partnering organizations, everyone from that person who checks that patient in, to the people at the patient's bedside, to the folks who are billing those patients. Healthcare workers must engender trust in their patients, build a genuine rapport, practically free from implicit bias. So where do we go from there? Liberation. Liberation from barriers to health for those who have been disadvantaged. And finally, I'd like to acknowledge Sarah Cook, who is Central Health's Senior Director of Strategy and Planning, who's been an active proponent of this work for the last 3 years, if not more. And Jessie Patton Levine, Central Health Senior Epidemiologist, who's worked tirelessly with Matt Richardson and Sally Gustafson to pull these data together. Thank you.
Thank you, Sarita. That was really NJP. Excellent presentation. The data is really compelling if you look at the fact that the majority of our enrollees are Hispanic, and that they seem to be experiencing some of the better outcomes. So as we look at how we can improve with our population, we need to focus our attention on those that are not experiencing the great outcomes and have an increased burden of disease. And it's very clearly laid out in your data. So I really, really, really appreciate the presentation, the work you and your staff have done. It really is truly excellent. So let me open it up now for any questions or comments that the board members may have with regard to this presentation. Manager Motwani.
I echo your comments, Chair, around the just how compelling this presentation is, and how appreciative I am to be able to have these insights. I have a few questions. The first, is around the overall enrollment with MAP and general demographic trends across geography. Curious, and certainly happy that we have access to this information now. Curious about what was preventing us from having MAP enrollment information, I guess, at the geographic level before. And I'm pretty sure it's a quick, straight shot answer. Please don't feel the need to have too much context. I'm just curious.
Sure. Two main reasons. One, the data collection system for our enrollment. For our enrollees, every year when they were re-enrolled, it would erase the old address. So it would write over it. And the second and more compelling reasons, we just didn't have the internal capabilities right now that we do right now. So we've built up the staff and abilities to look at this.
The first one is actually more compelling to me. Just wiping that away. I'm so glad that you nailed that down. And then secondly, when we were looking at, I guess, geographically rates of change in enrollees, would it be possible to get that? And I'm curious, looking at the enrollee change as a percentage of the total sort of utilization within that tract, or as a percentage of total enrollment within that tract. We were looking at just the number of enrollees reduced. And so it wasn't, for me, it didn't feel like apples to apples, because in each tract, I don't know how many were enrolled, right? So we would look at, wow, in this tract, we lost 2,500 enrollees. In that tract, we lost X number of enrollees. But to me, without knowing a denominator, it's, I think it would be more, a lot more interesting with the denominator. So I'd love if we'd be able to follow up, offline, or if you'd be able if I'd be able to look at something like that.
Yes, absolutely.
Non-emergent by any.
Okay.
And the first time that we are aware that enrollment has decreased by 13,400, and this may be context that I might have missed. Is there like a one or two line shot for sort of why we think?
Sarita doesn't like me to speculate on stuff, but I would say, if I could speculate, I would say COVID, number one, and then the advent of MAP Basic in 2019. We may need to work with some of our providers as far as enrolling patients in that program.
And meaning that MAP Basic is more difficult to enroll, or it's attriting from MAP typical?
It's a different process than the sliding fee scale. We now have a defined population of our own in MAP Basic, whereas sliding fee was often driven by the FQHC providers to enroll those people. So I think there may be somewhat of a learning curve in enrolling them into our system rather than their own.
And have y'all looked at?
Monica, did you want to add something?
Yeah, sorry, Manager Motwani, can I add something about that? And I'm sorry, I had to move because I'm having an unstable internet connection, so I'm trying to get as close to the router as I can. But I think it's not just that it's different enrollment processes, it's that it's a new program. So MAP Basic is a program that we have a relationship with the patient, and they're enrolled in the patient instead of just having a relationship with the community health center and paying a fee for sliding fee scale services. And also, part of the getting people enrolled in MAP Basic involved people who had been sliding fee scale coming in for appointments and then getting enrolled in MAP Basic. And if people, because of the pandemic, were not coming in for appointments, you know, like flu, cold, other kind of acute illnesses, they wouldn't have the opportunity to enroll in MAP Basic.
I see. Thank you. I'm wondering if, and I'm not necessarily asking for this information, but wondering if at some point, is there any interesting delineation in as much as what the results are if we were to sort of split what we're looking at? Like, let's just take, for example, the Latino population and look into that population with a slice of preferred language to see if there's any sort of change in trend where first language is English versus first language is Spanish. Have you all been able to explore that yet?
We have been starting to stratify these subpopulations. We are not ready to present some of that information yet until it's further analyzed.
I figured y'all are on it, but it seems really interesting to me, especially given sort of the gargantuan differences in outcomes in the Latino population as a whole, and wondering if, like, of course, as y'all are certainly looking into, slicing that in different ways might yield more insight. And on that note, sort of finally going to Sarita's presentation, which again was super cool and great to see, and knowing that we're talking about human beings and chronic illnesses, and that these are grave concerns at the human being level, the data analysis is very, very compelling and insightful and sort of invigorating in that way. And that looking at the, in particular, the chronic conditions, hypertension and diabetes uniquely, where the Black and Asian population were sort of carrying the largest burden of them. And it appeared that, like uniquely with diabetes, but also similarly with hypertension, the Asian population was perhaps more responsive, or the most responsive to the interventions. Is there any insight whatsoever on that, or why, or any speculation, or any maybe guidance on how we maybe could possibly dig down into that to see what we could replicate there?
I think that, sure. And anything I say would be pure speculation, so I'll shy away from that for now. So, but I think that one way we may be able to capture that or gain some insight there, maybe to distribute surveys to the populations. Just understand, we can certainly look at things like no-show rates that may be impacting their performance levels, and then send out surveys that ask, why didn't you show up to your appointment, or maybe not phrased that way, of course, but looking at medication, whether or not folks are following up and getting their prescriptions filled, if not, why. But again, it would require a deeper dive into the data, and coupled with a survey that asks those specific questions as to why, if we can't understand from the data itself why those issues may occur.
And
I really
to the basics, but what is the difference between MAP and MAP Basic?
Okay, good question.
Sure.
Who wants to go?
MAP Basic, generally speaking, is a program that is targeted towards Travis County residents at or below 100% of the federal poverty level. MAP Basic is a program we created in 2019. I believe it was launched in April 2019 to create a larger defined population that goes between 100 and 200% of the federal poverty level.
Does that answer your question, Manager Brinson? You're muted, so.
And that's the only difference, is the poverty levels?
Monica is saying no, so I will go ahead and recognize.
Yes,
All right.
there's some nuances, and I could jump down to John Morgan. I'm looking at the screen, or Monica, but it just depends on how much you want to get into this.
And Dr. Brinson and Manager Matwani, I'm John Morgan. I don't think we've had the opportunity to meet yet. And I think we're going to have some additional conversation tomorrow night, and we can certainly dive into some more orientation on the programs. But suffice it to say right now that MAP Basic is a much more limited program. It really grew out of the FQHCs and their sliding fee scale enrollment programs. And what we've done with MAP Basic is create a more standardized program that we reimburse for services in that environment instead of having separate benefits, separate patient financial responsibility, separate pharmacy formularies in each of the FQHCs. So it's been a process to standardize, but it's really focused on primary care, medical, dental, and behavioral health services and a pharmacy network. There are some additional benefits, but we can go into more detail on that at another time, if that's okay.
Does that answer your questions, Manager Brinson? Great, thank you. Before I go on, I've got Chair Greenberg, and were you completed, Manager Matwani? Did you finish asking already?
I just wanted to appreciate the acknowledgement of living in a system that has explicit and implicit racial bias, and and how that lines up in general with the research that shows that living with these micro traumas daily as a person of color can correlate with poor health outcomes in the long term. That's all.
Thank you. I'd like to recognize the fact that Manager Valadez has joined us, and also I did not recognize initially that Manager Musaiti has also joined the meeting. So thank you guys for your time and for joining us. Chair Greenberg.
Most of the questions and comments that I have been asked or stated by my esteemed colleagues, but I do want to really give a shout out to any and all staff who worked on this, because Manager Matwani, we have come a long way, a long way in our technology and systems, and bringing on the staff that we needed. And I cannot tell you, and I see Manager Valadez nodding, the difference now between now and the day that Manager Valadez and I got on this board, and the information that we were asking for then and what we are able to have now. So I just want to give a huge shout out to everyone, because, and I see Manager Valadez clapping too. So thank you.
Thank you, Chair Greenberg. And I also want to say, before I recognize Manager Valadez, that this is an ongoing topic for us, this data and looking at these issues and having this discussion with regard to how we approach the issues that are outlined in this data. This is just not something we put on a checklist and say, oops, we're finished with it, we're going to move on. This is not your first hit at the apple or at the piñata. You'll have many hits. And so I just want to make that to the members.
And Manager Bell, I do want to emphasize that this has been ongoing efforts in Strategic Planning Committee and others, and it's iterative, it's growing. I'm proud of it, and I know that it will continue. Thank you.
Thank you very much. Manager Valadez.
I'm sorry, what I was trying to do was say hello, that I'm here. But with respect, I just wanted to, because I did come on with Sherry, and I wanted to acknowledge the growth that has occurred not only in the culture at Central Health, but with the staff that has been put together to help us as a board make better and more informed decisions. And I'm very proud of them. I'm very proud of our enterprise. And even though sometimes it appears as if I'm being a bit critical, I'm only doing it in the best interest of Central Health, because we all as board members, I know especially Sherry and I, we only want Central Health to grow into being the best healthcare provider that we can be, health and healthcare provider by entering into those appropriate relationships and providing the necessary data for y'all to be able to do your job and keep us informed as we have to be in order to be held, since we're being held liable for the actions that we take with our taxpayers' dollars. So I just want to thank you all for being here. And I want to thank staff so much for what they provide to us, even though I can sometimes say I'm somewhat of a pain. I relish each and every one of you as board members and each of our staff members. Thank you.
Thank you, Manager Valadez. Appreciate that. Appreciate that a lot. Any other comments or questions from board members? I'm not seeing any hands. So thank you very, very much. I will lay out then agenda item number 3, receive an update on the Central Health Community Healthcare Initiatives Fund. I think it's called CHIF. Sarah Cook will be presenting.
Hi, everybody. Thanks for having me to talk about this item. A quick note of warning. I'm at Rosewood, Zaragoza right now, having worked at the vaccine clinic here today. And if anything gets glitchy, Monica Crowley will take over and continue on in the presentation. But I'm happy to report that we were projecting, I think, vaccinating over 200 people by lunchtime. It was very busy and very exciting to be here. So glad to be reporting to you from RZ. Today, we are going to be talking about this Community Healthcare Initiatives Fund, which, as Manager Bell noted, we're calling the CHIF for short. For those who have just joined the board and those who may have forgotten, I wanted to introduce to you why we're actually talking about a Community Healthcare Initiatives Fund. And that's because back in June of 2020, Mike Giesland brought to the Budget and Finance Committee a proposal that you can see excerpted in front of you, in which he described some of the complications that were arising from the various funding requests that the board was asked to field. And he suggested that we come up with a process to handle, evaluate, and more systematically and equitably treat those funding requests. And at that time, in June, he suggested the working title for this allocation of funding is the Community Healthcare Initiatives Fund. The board approved this, and towards the end of the budget process, setting up the current fiscal year's budget, that is fiscal year 21, a percent of the increase in the effective tax rate was dedicated for this initiatives fund, the CHIF. So currently, based on that allocation, I believe that for this year, there's approximately $875,000 allocated for the CHIF. And again, we are responding in this presentation to what Mike had proposed back in June of 2020 and are bringing it back to the board. We have some description to tell you about the program as we've conceived it so far, and some questions to ask the board around its timing, around the scope of the projects that might be of interest to the board to fund through the CHIF, and some other operational questions. Next slide, please, Brianna, thank you. So again, this Community Healthcare Initiatives Fund, we're proposing that we support projects that have a meaningful impact on health and that benefit the low income on and underinsured of Travis County, and that align with the annual budget resolution that the board also passes. More broadly, we think that beyond this immediate goal to support these projects that impact health, we see this as a vehicle to also quantify the health impact of funded programs and projects. So we'll be able to track a little better and a little more rigorously the impact of these funding choices that the board makes and the projects that are funded. And then we'll be able to align existing and newly funded projects to improve health outcomes within the shared framework and process. And this includes not only an evaluation framework that we would bring to the CHIF, but the broader work that's happening across the enterprise, including in that systems planning work that you've heard so much about, sort of, again, setting the blueprint for our healthcare contract investments for the next 10 years, and also making sure that this CHIF supports that broader scope of work. What we're proposing for this initial fund year, and I want to make a note now that I want to emphasize that this first cycle will really be a learning experience. So these proposals that you hear for how we might launch it would pertain to the first year, and then we'd be able to improve or change as required for any subsequent years. So this initial fund year, we recommend using a multi-award RFP process. We'd evaluate proposals within a cross-department and cross-disciplinary staff team. The Board of Managers would receive this evaluated and suggested slate of projects and approve it. Once the projects and the nonprofits were approved by the Board of Managers, we could start contracting negotiations with the funded organizations. Organizations would sign a contract and a standard business associate agreement with Central Health. They'd comply with all privacy policies and provisions, including HIPAA. They'd provide quarterly program updates on their project progress, outputs, and outcomes as approved by Central Health in the course of that program application and evaluation. And then we'd ask that they present the outcomes to the Central Health Board of Managers or one of our standing committees. After this initial fund year, we would of course take lessons and improve the subsequent fund years. I want to make a couple notes about this. Next slide, Brianna, please. Thank you so much. Okay, let me go through this and then we'll get to the questions. In Mike's June 11th memo that we referenced at the beginning, he articulated some of the requirements of the business case, which would really be the response to that RFP, include these items. And I just wanted to confirm with you, any project that's proposed for this sort of funding would have to align with Central Health's mission, and we've been explicit about how we expect that to happen in that RFP. We'd require a clear demonstration that the services would address system gaps or quality issues that improve access to care, including measurable impact on health inequities or disparities. We'd want to understand the program's proposed targeted population or the member population, including various elements, including demographic information. We'd ask about the diversity of leadership and staffing, which we could expand to include not only things like demographics, but also lived experience. We'd want to ensure that these projects would develop measurable outcomes, and so we would ask for the outcomes that the projects would anticipate achieving and the processes that they would use to measure and validate those, so we could be sure that we'd be able to understand the impact of the project. We'd want to do a financial review, understanding if there were other sources of funds for these projects and the organization more broadly. The sustainability of this project beyond the timeline of Central Health provided funding. And then financial reserves and contingency planning in the event the proposed initiative would encounter unanticipated events. So all these elements were proposed as part of our inclusion in the application process back in June. And we've designed a sort of outline of that RFP application that would incorporate all of these. So we just want to confirm to y'all that we're following, again, that June 11th memo and what was laid out to us. Next slide, please, Brianna. Thank you. And so this is the portion of the presentation where we're really looking for feedback from the board. We're interested in discussing the commitment, and I have some updates on timing, and I know that we have Jeff Knodel on the phone as well, and he may be able to provide us more information as needed. Want to talk a little bit about the intent and the scope. How broad do we want this to be? What sort of projects do we want to fund? And then, of course, just some first-year operational questions that we want to run by you, again, about that very first application cycle, knowing the whole time that we will iterate and improve as things go on. Let me see. So confirming the commitment. As we discussed, there have been funds set aside for this in this fiscal year. We can launch an RFP as soon as possible, going through, of course, our processes designed to do so. We could try to fund projects as soon as this summer. Alternately, and this may be more appropriate based on the financial circumstances that have arisen from COVID, we could reallocate those funds that have been set aside for FY21. Take our time to marshal the RFP, get the word out on the street about it, inform our community that this opportunity is arising, launch that RFP then this summer, and start these projects with funding on October 1st, 2021. So perhaps we want to take each of these questions sequentially. What would you like to do, Chair Bell?
I'm with you on that, Sarah. I think we should just get some comments on each of these issues and then move on. So the first one, confirm our commitment, and the questions that were put forth by Ms. Cook. Board members, do I have some input from you guys? Chair Greenberg?
So I'm not sure if this applies to this one, but I know, Sarah, you brought up not rushing this and perhaps waiting till October. And to me, that is quite sensible. And also, given COVID, the allocation of funds. So I'll just put that out there, that I think for all the reasons that you enumerated, that to me sounds very sensible.
Thank you, Chair Greenberg. Appreciate that. Manager Valadez?
I agree 100% with that suggestion. Thank you for offering it, Monica. Was that you?
No, it was Sarah.
Sarah.
I can't see. Sarah, thank you for offering that. You know, the pandemic has impacted our families and our community more than we can even begin to imagine. And I think that we're going to have an ability to allocate and support the efforts that have been ongoing that were not previously funded, because we didn't know this was going to happen, including with the ice storm. So I'd rather we do a slow start and reallocate those funds.
Thank you, Manager Valadez. Manager Musaiki?
Thank you, Chair. Appreciate it. Thank you, Sarah. I really like this project, given that we now have a process in place for entities to come and see.
Manager Misaitif, I'm having a lot of trouble hearing you.
Question.
Manager Misaitif, you're fading in and out.
Can you not hear me?
This is better. You probably need to take out your earbuds.
Try this. Yeah, I'm trying. Can you hear me now?
That's much better, yes.
Thank you.
Okay. Sorry, multitasking here today. Okay, can you hear me?
Yes, definitely.
Okay, perfect. Thank you. The questions that I have, I'm pulling out are a couple questions. In terms of the inclusion criteria, the last one, financial reserves and contingency planning in the event proposed initiative encounters. Are you referring to central health reserves? And B, in terms of the timeline, I may suspect that some of the projects that will come in place are much needed to combat this pandemic. So if we start a slow start over the summer that can help us facilitate whatever issues that our community find relevant, I don't see why we should wait until October. We can have a slow start with this initiative. So that's really my points that I have from this project. But otherwise, you know, I fully support it.
Thank you very much, Manager Musaiti. Manager Brinson, any comments at all? No? And Manager Motwani?
I'd like to defer to the chair. You had her hand up to say, okay.
Now, please go first. I'll ask a follow-up question after you.
Then I just want to say how great I think this is, and having been able through other avenues to have seen, I think, glimpses of it even in just nascent, sort of pre-nascent stages. It's great to see it come to fruition. I think it's a culmination of a long chain of planning and thought, and it's reflective of this chair's leadership and CEO's leadership, Sarah, yours, and all of the team, to bring something like this to life. I think there are a lot of things that will be worked out, as we're ironing out some of the nuanced details. And I think that's really, really well thought out. Now, that being said, I'm wondering, I have two questions. One, which is that, and they don't need to necessarily be addressed here in the interest of time, because I don't think that they're necessarily pivotal. The first is just, is there a model for this? There's going to be a lot of early learning, right? There's a learning curve in this, and especially when anytime we're talking about iteration. Is there a model for this that we have locally, or that's been done? Or is there guidance around it? Likely, of course, from Robert Wood Johnson Foundation, among others. But is there something we could look at to kind of get best practices, at least at the level that we're trying to do it? And then secondly, I definitely would also prefer, my druthers would be to do a fall start, a start in the fall. I think that sounds better than a fall start. Just make sure we have it all cooked, especially given all the variables that are going on right now, and any unanticipated things that could happen before then. However, wondering about, and I know that that Jeff will be able to sort of address these things later, if there may be financial implications to actually reallocating 2021 funds, if we lose something in that somehow, like by means of displacement, or if there's like some kind of slick instrument that we could, use, like to sort of escrow something and keep it, around later, or maybe have a bigger one next year because of that, or something like that. Just wondering if all that stuff's been examined. And I'm not a financial person, so I wouldn't know like what our avenues of that are. I know y'all have thought those things through. So thanks.
Thank you, Manager Motwani. Mike?
Yes, I can. I'll answer a part of your question there related to, is there a model that's out there, and then I'll defer to others on this one. But this is a combination of looking at a bunch of different things that have been done, both inside the central health enterprise, but also externally. If you think about other programs that are trying to tie something back into a larger system type approach with measured outcomes. But the one thing that really jumps out in my mind is something that I paid a lot of attention to as we were thinking through this, was our very own district program. When you think about staging and structuring, and then having results and outcomes and having it be linked to something, that's something that and that's just purely subjective on my part. But again, defer to others to help answer some of the other like models that are out there that have been looked at.
I'll jump in with a quick update on that. We looked hard for parallel programs, but as you know now, and certainly will grow to understand even more deeply, central health is so unique in this landscape that because we are who we are and how we are, we can't exactly replicate things. So for example, we have a complicating factor of requiring the RFP, which will feel a little more, I think, heavy duty to some of our community nonprofits, which is why I think that that communication and hand-holding in the application process may be more important. We can't simply make grants for things. We have to fund projects with health outcomes based on the nature of what we do in our structure. So in that way, we're unlike a foundation or a grant-making organization. So there were, we got the flavor of some other programs, but we really did have to create this with our own parameters, just given how central health operates.
Thank you, Sarah. Chair Greenberg?
Yes, so a couple things. I really appreciate all that has gone into this, because we have had long discussions about we must tie this to our strategic plan, our mission, our goals, and have outcomes, absolutely, and outcome measures, as any foundation required. But also one model, I think, Sarah, you looked at this early on because I mentioned it, we are a local government entity. And so, yes, we have to do RFPs, but this is not unheard of. The city of Austin does that. Neighborhood Housing Community Development has done this for years with the general obligation bonds, and I'm on the Housing Investment Review Committee, and there's a similar process, and there's a criteria to grade and outcome measures. So it's certainly, understood if you are a governmental entity. Beyond that, I do have a question when we talk about the funding, and Jeff can get to Manager Motwani, your question, but it's not like we use funds or lose them. We have reserves that can go into through the budgetary process. We can allocate them. So we're and I know Jeff can elaborate on that more. But my question is, I see the partial funding of requests, and this really comes from the work I've done with the Housing Investment Review Committee and what we look at, and that is, should we have something where we don't fund over a certain percent of a project so that we know that the entity has, skin in the game, equity, and we top off? A question that I'm going to just put out there, doesn't have to be answered now.
Excellent question. Excellent. Jeff, did you want to add anything or no?
No, I think some of the questions are actually questions that we will ask during the next budget cycle. So for example, these are all set up on, via appropriation. So we'll propose a program next year to, I guess, what we're calling roll it forward. And then we'll have, that will be part of the budget process, is we'll ask, do we want to use level funding from 21, or did we want to kind of mold 2 years worth of funding into this initial period? So as far as processes, there aren't any gotchas or red flags related to the funding of it, other than we go through our typical budget process, and it ultimately is up to the board to approve the funding for this program.
Thank you, Jeff. Appreciate it. It appears on the first item that the majority, including myself, would like to see the start October 1st, 2021. So let's go to the second item, revisit the intent and scope.
Well, pulling some of the text from that June 11th memo, Mr. Giesland talked about wanting to fund proven and sustainable programs, and was interested in focusing on programs that were that described future access to care. In the course of our research and development, I think that there are some competing themes where, again, we need some board direction. Proven and sustainable programs imply that we would be looking for maybe larger organizations that have capacity, who have already run programs, which might make it harder for new and promising organizations with whom we may not have contracted, or who may be nascent themselves, to participate in this. So I think we want a little bit of feedback on how proven and sustainable those programs are. And again, the first fund year can be different than subsequents, but also understanding that the decision here and the direction will influence how large the program becomes to manage internally at Central Health, of course, and also, the burden on the selected organizations. And then one additional thing under intent and scope that isn't articulated here is, again, that memo describes future access to care programs. That can certainly mean a lot of things. Do we want to focus on getting people into doctors' offices or adding additional capacity? Do we also want to include outreach to improve health access, or basic needs for health? Or do we just want to focus on funds for service expansion? Now, this is a lot, and Chair Bell, I look to you to marshal the conversation, but these are some meaty issues as we develop this program that I think we'd love some direction from the board on.
Thank you, Sarah. Appreciate that. Manager Brinson, great comments. Unmute.
Well, I wanted to comment on what that last point was, and I think that I don't think we should hem ourselves in too much this first year. I think that will take time. So I think I would be more open to not just working with people we've worked with in the past, and not just large organizations. I think we should think about expanding our relationships with the community and doing smaller projects if they're appropriate.
Thank you, Manager Brinson. Appreciate that. Manager Musaiti.
I would like to echo with what just said. I think excluding small organizations will not fit in if into our mission of really addressing equity, because sometimes these small organizations do not have the means or access as other larger organizations. So I would definitely encourage us to reach out to smaller organizations. I think sometimes great ideas may come from these organizations that can overall fit into our mission overall. So that's really, yeah, I'm going over these questions really. And in terms of sustainability, can you elaborate more what, Sarah, you touched upon the sustainability of the programs and what Mr. Giesland hopes to strive. I didn't catch you. So if you can talk a little bit more about what you meant in terms of sustainability of these programs.
Either Mike or Sarah, either one.
Yes, I'll start out. What we were looking for, actually two main points on this one. One, we didn't want to become either intentionally or unintentionally a budget stopgap for any one particular organizations or consortium, and where it just became year over year. This is a source of revenue. We needed to make our budget. And the second main key takeaway is on the sustainability, is that the business model was such that, yes, there may be continuing investment, either from us or other sources or a combination thereof year over year over year, but that was it sustainable? Meaning, for what you were investing in it is the patient seeing the outcome, the people that we serve seeing the outcomes. So that's what I meant by sustainability. Certainly, if there is a financially standalone model, hey, that's great. Let's take a look at that. But at the same time, realizing that this is going to take continued investment.
Thank you, Mr. Giesland. Anything to add, Sarah? Okay. Manager Musaitis, does that answer your question? Great. Any other comments on our second point here, revisit intent and scope? Manager Valadez.
Dr. Bell, and thank you, Mike, for having done that. I know that you and I had been speaking for about 3 years now on a resolution that was going to address organizations coming to Central Health and looking for them to be a source of revenue for them. And I think that became, unfortunately, more apparent when the legislature took action on limiting cities and counties or government entities to that 3% limitation. We started seeing organizations come and ask Central Health for money. My concern was at the time, what is our process? For evaluating the request? Do we have something in place? What have we done in the past? And where are they getting their money from? If they're an existing organization, who else is providing monies to them? What I did not want us to become is, I didn't want the organizations to think they could come to Central Health and be double dippers or triple dippers, where they're asking for dollars that they have already been funded for from other entities to do the same thing. We have a mission. We were created to provide healthcare to the uninsured, to our poverty population. And what we would like, what my idea is providing help and assistance to those organizations that are going to help us move the needle. And that is to overcome the disparities gaps, to close close those disparities gaps, to help us achieve our mission, and to make sure that that those results, those outcomes are actually, if they're great, we want them to become part of our protocols and our practices within Central Health. So if they can teach us something, then we want them to be able to do that. And so, it doesn't really matter to me what the way or the shape that is presented to us or that they come to us. What is important to me is that they have ties to the community, that they have at least some proven successes, as opposed to just whatever, or at least an ability to show us that they can be successful at achieving their goals. That's all. But also wanting to make sure that there is no duplication of dollars for the same thing that is being provided to them somewhere else. That's all.
Thank you, Manager Valadez. Any other comments? It appears that, Sarah, that there is a majority that feel that we need to consider new and promising organizations that may be smaller than your larger organizations that have a large amount of capacity. And then we also need to follow the sort of definition that Mr. Giesman has outlined for proven sustainable programs and incorporate that in our sort of analysis of the individuals who apply. So I think, as many of the members have said here, it's going to be a learning process for us, but does that give you enough feedback to sort of move forward? Thank you, Sarah, appreciate it. And then your first year questions, Sarah, you want to sort of outline what you need from us?
Sure, and I think that we've gotten some feedback since we prepared this presentation that will help guide us. But if the members feel strongly about any of these issues, I would suggest making a comment now, but I think we feel a little more confident in our approach. Do we want a minimum number of projects to fund or a maximum? Is that important, or should we just look at the proposals as they come in, rank them, and fund as many as possible down the list? I think we feel a little more comfortable with the second approach, but if the board feels strongly, then we'd like to know. We had started with this $40,000 to $400,000 funding band because a $40,000 program would fund one FTE at $15 an hour plus benefits. That's how we derived that number. And then the 400,000 was just a little different than that. But what we have heard is that 400,000 is probably too high for what we want to do. So we've been encouraged to make that band of funding possibilities a little smaller. We've heard from $50,000 to $150,000. So we want to confirm with the committee that that feels better. As far as partial funding of requests, I think that that's something that we can determine, as Chair Greenberg suggested. That's practice in other places. Again, for this first year, we may just want to try to fully fund projects. As far as multi-year projects go, this is a great question and shows some of the tension between sustainability and programs that may need some additional assistance. We're going to propose that we include some language in that RFP along the lines of, for applicants that propose multi-year projects, funding is not guaranteed each year. And we encourage organizations to look for additional funding beyond the central health supported program year, which neither says we won't fund you again, but does not guarantee funding. So that's how we thought we might approach that. And then I think a broader question for the board, this is more philosophical and policy oriented, is how we want to incorporate any of our existing contractual relationships for non-clinical services into this framework. That may not be appropriate for this first year as we get our feet under us, but there are lots of wonderful programs that improve access to health and address basic needs for health, and again, that may at some point be appropriate to incorporate into this, though not necessarily so. So those were where we landed, and we welcome any additional discussion.
Thank you, Sarah. So in essence, you feel like you have pretty good feedback so far. If anybody here in the committee has anything that they would like to add or that gives them concern and they want to make their comments known so that they can be considered, please provide us with that. Any takers? Okay, let me start with Manager Valadez, and then I'll do Chair Greenberg, and then I'll do Manager Motwani. Manager Valadez.
Thank you very much, Chair Bell. One of my big insights into how governmental entities look at how they spend their money and what they get for it was sitting in on the audit reports to the city's audit, financial and audit committee. And that proved to be very enlightening and eye-opening. I found that there were organizations that had been funded for more than 12 and 13 years and never submitted any budgetary or financial paperwork. I found that with legacy contracts that were given with basically no outcomes demanded or expected. And so what I don't want for Central Health to end up being this kind of an entity. I want us to be responsible with how we spend our money, understanding that our mission and why we were created legislatively was to provide services to our underinsured, our uninsured, and our poverty population, our vulnerable population. So that's all I would like to say with respect to that. Thank you.
Thank you. Thank you very much, Manager Valdez. Chair Greenberg, please.
Yes, so I mentioned earlier looking at whether or not we would only cover a percentage of a total project, so there was skin or equity in the game. But in addition to that, I certainly concur that this is not to be a continuing just fill the gap in the budget for an organization. This has to be tied to us. We have a fiduciary responsibility, and we want accountability, and we want outcomes. And along with that, I do not believe that there should be any minimum number of projects. This should be based on whether the projects meet our criteria, not some minimum number. And then next, I would just encourage that as we move along, and I know you'll be working more on this, that of course, when you're going to send out an RFP and you're going to get responses, that there needs to be a matrix of evaluation criteria that takes a lot of these things that we're talking about into account. And there could be weighted, numbers applied, points applied, and I'll leave it at that.
Thank you, Chair Greenberg. Manager Motwani.
Thank you. I certainly agree with the 50 to 150 range. And, I was going to say that it's almost, having been on both sides of the funding equation, that it's easier and more manageable, especially for first timers, perhaps to have sort of an encapsulated number of awards, that will occur, and sort of fixed amounts of those awards, as opposed to, ranges that would, maybe require permutations or adjustments to be able to make the final number all match up. Something like X number of awards for 100K and X number of awards for 75K and X for 50K or something like that, and just know there are a fixed number of awards. But hearing what Chair Greenberg said, wow, that makes a lot of sense. And so I'd rather approach it from that angle. And maybe however else we may be able to just create administrative, I think, simplicity, do that. So yeah, I guess I needed to think that out loud, and I appreciate y'all kind of accommodating, that 40 seconds of burn time. And in addition to that, the language around "we may not fund you next time," it's really common language. Pretty much every single grant I've applied for says it, unless it's a multi-year opportunity anyway. And it's almost as if, again, I just really appreciate how well thought through this is. It's almost as if your recognition of that, I would support taking it a step further, and even almost implying that there's a low probability that this will be refunded. So that those expectations are managed at the front end, and it allows the enterprise to perhaps invest in more and different innovative ideas the following year, and of course have the option to refund something. But in my view, if something really is producing outcomes, it's a good project. If it's got a track record and it's got measurable results, it's going to get investment from somewhere else. It's going to, that's going to be something that's going to be able to be shopped around within that same fiscal year. And folks will be leaping to support it, especially if it's demonstrating the types of outcomes that we're requesting here. And again, that's sort of confident speculation, but it's just my opinion on it. Thank you all.
Thank you, Manager Motwani. Manager Brinson.
Well, I want to make a few comments. One is I do not want to have either a minimum or a maximum number of projects. I also don't want to be obligated to spend all of the money just because we have the money. So I would like us to be able to choose projects that we think are valuable. And then if we don't spend all the money for that year, we just put it aside perhaps for the next year or whatever is needed. I do think $400,000 is too much, and I would feel very comfortable limiting it to below $250,000. But I don't mind funding a little more than the $100,000 idea. So I'm liberal on that. I don't want an emphasis on multi-year projects. One of my hopes is that what we'll do is we'll learn through a project whether this should actually be incorporated into the central health system. So I don't want to really emphasize multi-year projects, with the hope that we'll get small projects that are easily incorporated into what we already have. So almost like we'll be learning from this. And I don't have an opinion on the fourth point.
Thank you, Manager Brinson. I appreciate that. Sarah, does that provide you with the feedback that you need?
It does. And perhaps Mike or Perla or Monica could tell us what the next steps will be. I think we'll be coming back with more information and update to the full board. I just want to confirm that, and we'll certainly incorporate this in the rest of the planning. Thank you so much for all of this assistance today.
Thank you, Sarah. Mike, did you want to outline next steps or no?
Yeah, so I think actually Sarah touched on it. It's taking this feedback, which has been incredible, and thank you, members, for the open and honest conversation, and then putting some more form and structure to what we have, and then bringing it back. We want you all to be 100% supportive of the direction that we take.
Okay. Thank you very much. I appreciate it. As a time check, we have 2 minutes until 2:30, but I'm told by Sarah and JP that this update that we're going to get in our next item, it shouldn't take that long. So agenda item number 4, receive an update on the Central Health Board reporting dashboards and strategic objectives. Sarah Clark-Leach, Ashley Levulet, and JP Eichmiller will be presenting.
Thank you again, Dr. Bell. Ashley's going to project this, and while she's getting that ready, I'll just give a little intro. In early 2020, staff brought forward a dashboard menu to this board, and we outlined various data points that could be developed into dashboards and then publicly published through our website. This included data on enrollment, utilization, demographics of our enrolled and the total populations in the county, as well as current and historical maps of our provider locations, which are then broken down by service line. The purpose of this work was to better inform the public, stakeholders, and also employees of Central Health about the work we do and we serve. So with that, I'll hand it over to Ashley, who will be providing our scheduled quarterly updates on our dashboards.
Thank you, JP. So I'll keep this quick. As JP mentioned, we will be reviewing Central Health's external facing dashboards. Currently, there are 2 dashboards that are up on Central Health's website under the Our Work header, and that is the Enrollment and Clinic Utilization dashboard, as well as the Provider Network dashboard. Central Health's public-facing dashboards continue to be updated on a monthly, quarterly, annual basis. Additionally, the Enrollment and Clinic Utilization dashboard undergoes monthly internal HIPAA reviews to ensure compliance before the data is updated. So some updates since the last time we shared this dashboard with the Strategic Planning Committee. We now have both a mobile and desktop version of the dashboard. The version that is currently up on Central Health's website actually detects the screen size that the dashboard is being viewed on. and it will display the optimal version of the dashboard given that screen size. Since the last time we shared this dashboard, we have had annual updates to the demographic and enrollment data, as well as the visit data by census tract. So that has been updated from fiscal year 2019 to fiscal year 20, and that is the portion of the dashboard that is highlighted there on the right. Currently, the most recent monthly data available in the dashboard is for January of 2021. The February update of the data is scheduled to be added at the end of next week. Some highlights since the last time this was shared. As of January 2021, so since the end of Q1, we have had an increase in the count of actively enrolled members of 850. That breaks out to 499 MAP members, 705 MAP basic members, and a decrease of 287 sliding fee scale members. As was mentioned earlier, the decrease in sliding fee scale is expected as we continue to enroll more members into MAP basic. Additionally, I'll quickly go over some of the updates on visit totals so far fiscal year to date. So in FY21, we have reported 38,217 visits, for which we currently have a claim. This is an undercount because of lags that we have in our billing cycles. So those monthly counts will continue to go up as we receive data. As it stands in FY21, nearly half of all visits so far today have been primary care visits. Alternative and specialty care visits represent the second and third most frequent type of encounters that our members are having with central health providers. And quickly here, just some updates on the Central Health Provider Network dashboard. It was actually just updated. So as of now, there are currently 167 providers mapped within the dashboard. That represents a 129% increase in the count of providers since FY16 and a 174% increase since FY13. Primary care, specialty, and preventative screening providers currently represent the majority of providers within Central Health's network. And that is it for this quick update. Thank you.
Thank you very much, Ashley. Members, first of all, I'll say that we were slated to carry on until 3:30. So in essence, we might get out early. So any questions, comments from that update by any of the members? Manager Valadez.
Mine's going to be a 1 minute. And I just want to thank Sherry for being the data guru and demanding that we get all the information that we need in order for us to do better. Thank you. And I want to thank Mike for using DSRP as in the previous conversation as the example on which to base your memo, because that was exactly appropriate and perfect. Thank you. Bye.
Thank you, Manager Valadez. Any other comments, questions with regard to the update on the dashboard? Manager Motwani.
First, it's just a really great dashboard. It's just really, really cool. It looks great. And it's got so much information. It's digestible. You know, a lot of these things don't get acknowledged as much as they should. You know, in addition to having good information that's relevant and salient, it's also, you know, consumable, and the user experience is nice, or it appears to be, and so great work there. Secondly, on the part of all the leadership here in the room, as well as every staff member associated with the same, what aggressive growth in specialty care providers, you know, especially since 2016. I mean, yeah, thanks for doing that.
Thank you, Manager Motwani. Any other comments or questions? Okay, seeing none, I will lay out agenda item number 5, which is to confirm the next Strategic Planning Committee meeting date, time, and location. Managers, our next Central Health Strategic Planning Committee meeting is tentatively scheduled for Wednesday, April the 14th, 2021 at 1 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702, and or remotely by video conference, depending on the status of the governor's disaster declaration and stay-at-home orders. At this time, I'm ready to accept a motion for adjournment. Manager Valadez.
No, I was seconding Sherry's motion that I heard her saying.
Okay, then I have a
I move
motion by Chair
adjournment.
Greenberg.
I move adjournment.
Thank you. I have a motion by Chair Greenberg. I have a second by Manager Valadez. Any discussion? All in favor?
Aye.
Any opposed? Any abstaining? We are adjourned. Thank you so much, members.
Thank you, members.
Thank you. Thank
Thank you,
you.
team. Appreciate you.
See you again soon.